accomplished head and neck onco surgeon. Vikas, over to you.
Thank you, sir. Thank you for the kind words. A very good afternoon to all my teachers, my seniors, and colleagues in the audience. Dr. Vikas Agrawal and Dr. Tushar have made my life quite easy. Before the onset, I like to tell you that robotics is in a very nascent stage. We've got a stalwart of robotic surgery in our audience, so that makes my life a little bit easy. I shall be talking about robotics in otolaryngology surgery with artificial intelligence at the forefront. So before we go on, I would like to define both the terms. Artificial intelligence is simulation of human intelligence by machines, either by learning, by reasoning, and by self-correction. And robotics is an interdisciplinary branch of engineering and science, which basically deals with design, construction, operation, and use of robotics. So how are we going to go about today's lecture is, we define robotic surgery, we define the artificial intelligence, and then we see how what the future holds for us. There is a powerful Sanskrit shloka which is related to the artificial intelligence, which says, Aklani mehati vidyati, aklani mehati buddhi, aklani mehati sthiti, aklani mehati mati. In essential, it means accuracy is the essence of knowledge, is the essence of wisdom, is the essence of stability, and is the essence of intelligence. So with this, Dr. Joseph Engelberger, he developed the first industrial robot in the United States, the Unimate, in 1954. Although the name robot came much earlier than that, in 1920s, a Czech writer, Mr. Karel, wrote a play called Aiorl, which is Ramosi Universani Roboti, in which the robot word was used for the first time, which essentially meant forced labor. An irony, but yes, it meant forced labor. So in 1930s and 70s, a lot of research began to happen on industrial robots. NASA came up with the idea of telesurgery to potentially provide support for astronauts while they were abroad the space station, and DARPA then started researching telesurgery for long-distance battlefield surgery. So over a period of next 1-2 decades, a lot of robots started to come into purview. The first one was Puma 560, which performed the first stereotactic brain biopsy. Then Probot for transurethral surgeries and the Robodoc for the orthopedic surgeries. DARPA gave us the concept of telepresence and robotized telemanipulation. The history changed in 1995 when Intuitive Surgical was founded by Fred Moll, and after that they completely dominated the scenario. So in 2001, the first Lindbergh surgery was performed, wherein two doctors sitting in New York City performed a first remote surgery for the patient who was in Strasbourg, France. It was a gallbladder removal surgery, and the latency time for this surgery was 155 milliseconds. The ideal one is 100 milliseconds, so they were not very far off the target. The Zeus system eventually got discontinued in 2003 because computer motions were purchased by Intuitive Surgical, and the photograph that you see in background now became the dominant photograph, the dominant players in this system. So what are the classes of robots that we deal with today? The most common one, the one that we use, is master-slave manipulators. So in which the surgeon is the driver of the master control, which is made up of electromechanical arms. The manipulations are transformed into position and orientation vectors by encoders. Computer software then runs the kinematics of the electromechanical arms, which then gets translated into a surgeon's gesture in form of a numerical pose. Then there are automated machines which operate by the following a list of coordinates, either to access or to work. The only example of this is a Probot machine, which was developed in London, and in ENT surgery still in the conceptual phase, but they are trying to work out various robots which would give us rapid and accurate mastectomies and probably would do even a frontal drill out. Then the future is collaborative robots, which can work both as an automated machine or act with cooperating with the surgeon. Handheld surgical robots, which are still conceptual as in today, but they are being designed. A few prototypes have been made, like this Micron system, which is held by the surgeon, which aims to remove the tremors, and it would be essentially very beneficial and being made essentially for stapes surgery. While we've talked about a lot of robotic systems, the one that we use today, the one in vogue today, is the comprehensive master-slave arrangement. So we'll go into a little bit of detail about it, which consists of a surgical cart, a vision cart, and a surgeon's console. And you see, this is how generally a robotic OT is set up. And you can see where the lightning bolt is, where the surgeon is sitting. And in the surgeon's console, we've got a main master unit, which creates a three-dimensional image for the surgeon. it acts as an interface for the surgeon where he gets to control the camera, the instrument. He can focus the adjustments and the electrocautery. There is a vision cart, which has got the light sources, the encephalator, and the hardware that eventually generates this three-dimensional image. And finally, we've got a surgical cart which has although four arms. In ENT, we use three arms. One holds the camera, and two other arms which hold various instruments that we require. So this is the real-time setup. Again, you can see this is the exercise system wherein two surgeons can sit at the same time. There is an assistant cart, there is a vision cart, and you can see now. You can see this is essentially where the magic happens. The movements of the surgeon get translated into the master console, and from the master console get into the manipulator control, from where it goes into the slave manipulator. And once it is into the slave manipulator, see what happens. It gives us, with these minimal motions, it is giving us 7 ranges of motions: left, right, up, down, backward, forwards, yaw, pitch, and roll, with which multiple things can be carried out, like clamping, cutting, dissecting, ligation, and even suturing. So I think this has already been covered by my predecessors, that robotics, if it's the face of the future, so what happens to us? What about us? So the advantages that we have, which is the judgment experience, which can never be taken away, is going to stay there. But the certain disadvantages that we have, like fatigue, variability in skill that should change with my state of mind, would change with my age, ineffectiveness at sub-millimeter level. So the robot is not really here to replace us, but to augment us, because it's going to give us, as I initially said, repeatability. It's going to give us accuracy. It's going to give us multitasking. And when in comparison to various other modalities that are available to us, again, it augments humans by giving us tremor filtration, motion scaling, reduced line of sight limitations, and clutchable instruments, which give us a lot more degree of freedom than our hands would. So it's kind of augments a surgeon. In applications for ENT HNS are varied. I would cover them rapidly, one by one. First one is transoral robotic surgery. As Dr. Vikas has already told us, there are a lot of procedures that are being done today for OSA, like lingual tonsillectomies, UP3, supraglottoplasties, a lot of surgeries that are done for neoplastic lesions like radical tonsillectomies, tongue-based resections, supraglottic laryngectomies, for neck, transoral robotic thyroidectomies. This is one of the cases that we did in 2022, and you can see there is a well encapsulated mass in the right and left parapharyngeal space. So the surgeries, how we go about is, we give an incision over the pterygomandibular raphe, we expose the parapharyngeal space, we remove the tumor from all around. We have to do a little bit of finger dissection for the superior middle aspect of the tumor where it is stuck. And finally, we are able to remove this specimen in toto. This turned out to be a pleomorphic adenoma. And after that, we did a lot of surgeries where we were able to do transoral robotic surgery for parapharyngeal space tumors. Recently, it has gotten accepted also for publication, where we are talking about changes in the paradigm of surgery, how it is helping us these days. Since 2008-9, once FDA approved transoral robotic surgery, there has been an upscaling in number of people doing this surgery, number of people addressing various issues through the surgery. But does that how does it really compare to the gold standard that there is when we talk about malignancies? The gold standard for oropharyngeal surgery still remains to be the IMRT. Vis-a-vis that, if you see, it's comparable, if not better, in terms of the overall survival. 93, 100, 97, 100%. So quite significant results as compared to the gold standard that is out there. So more and more people are now trying to perform transoral robotic surgeries in conjunction with neck dissection for early oropharyngeal lesions. Meta-analysis by Kelly et al. Has shown that there is no significant difference between transoral robotic surgery versus concomitant radiation in terms of overall survival, which is again is a significant step. Then people have started talking about doing a lot of robotic thyroidectomies. Endoscopic thyroidectomies and robotic thyroidectomies started their journey together, and both have been going at a neck-to-neck pace, and both have been improving quite rapidly. In fact, there are a lot of classification systems which have come up. You might keep reading about ABAs and BABAs and RATs. So few of them I'm trying to show here. This is a gasless unilateral axillobreast, or the axillary approach. Second one is a BABA approach, bilateral axillobreast approach. Then we've got a retroauricular approach. And now the one that we are performing these days is a transoral approach. when you compare all these thyroidectomies, so most of them give us essentially good results. But what stands out is the clarity of surgical view that it provides us and the cosmetic satisfaction that is common across all the stages. And also, I would like to tell you that we are no longer limited by central compartment. With this, we are able to perform total thyroidectomy, central compartment dissections, lateral compartment dissections. So robot is going to come up in a significant way as the years progress. People are doing robotic parathyroidectomies, even rhinology. Dr. Vikas has already covered, but as of today, it's got a limited role, and the role is especially for sphenoid and cellular surgeries. A new Scott Brown, in fact, if you see, talks about nasopharyngectomies for salvage cases where we have to do a palatal split and then we can expose the entire nasopharynx and remove the tumor. This is a concentric tube dual arm robot for transnasal surgeries. The concept came in 2011. It's already, the prototype has been developed, and probably in the years to come, we might see this robot in action. In otology, already there are a lot of studies. Again, my predecessor did show a lot of videos on that. People are doing robotic mastectomies for stapes. Robot has already been developed, SH robot. For cochlear implant well drilling, there is a robot by RX130, which is already in action. In fact, how does it really help us? There was a study which compared the translational, how it compares the amount of force that is done applied while we are implanting the electrode. So they compared the traditional versus the advanced offset techniques using a robot, and they told us what they showed us was that it minimizes operator variability, it maximizes repeatability, and more importantly, when a cochlear implant electrode is inserted via this advanced offset technique, it lowers the average and the maximum insertion forces compared with the traditional insertion. So it's far more accurate than we are. Skull-based surgeries. This paper came out in 2007. It was a cadaveric dissection by Hanna et al., where they did a bilateral sublabial incision followed by a bilateral cadaver antrostomies and posterior septectomy. And if you can see the amount of area they were able to expose, after this, you can see the endoscope has gone through the nose and the clutchable arms have gone through the antrostomies. They've exposed the sella turcica after sphenoidotomy. They've exposed the sella turcica, the palacellar space. They've exposed the cribriform plate. They've cupped the optic nerve. They've opened up the dura, and you can see the frontal lobe. In fact, they went on to suture, did a dural suturing also through this same robot. And after that, a lot of people started to venture into this field as well. A lot of papers since then have already come into this foray. And although if you see the previous slide, it is completely dominated by Da Vinci robots, but other robotic systems have started to being developed and they're not very far off. So the new ones coming up, like the Flex system by Med Robotics, the Solo Assist, they're also going to be changing the future as we see. This again, I showed you once, and this is the John Hopkins University robot that I showed you, being used either for nasal surgeries or for stapes surgeries. In pediatrics, it's not FDA approved. A few surgeries have been done, but they were abandoned, and they were primarily used for laryngeal clefts and cleft palate. The Firefly system has already been integrated into the latest robotic system that we use, and which basically is going to give us the functional and the physiological assessment while we are operating. As you can see in this parathyroidectomy surgery, the recurrent laryngeal nerve has been exposed, and while we are operating, the thyroid and the parathyroid light up when we start the ICG. As we go to the next slide, we can see the thyroidectomy is being done. And while we are operating the Firefly system with the ICG injection, lights up the thyroid, give us absolutely clean planes so that we can perform the surgery with a little more precision. And this is not future. This is already incorporated into the robotic system, which we are using presently. When I look at it, looks like playing on PlayStation 5. So the question is, can I also start working on that? Can everybody in this audience right now? Yes, absolutely. Why not? All it requires is a little bit of effort. So what's going to happen is there are going to be some video-based discussions for procedures and troubleshooting, then patient-based training, mentored virtual reality simulations, a little bit of dry laboratory testing, then mentored wet laboratory simulations before you can call yourself console proficient. And after that, everybody else can do the same surgeries as well. So whatever I've showed you till now is already so futuristic. What else is there to achieve? So what next is giving robots surgical intelligence, which is going to speed up tedious surgical procedures. It's going to perform difficult procedures which require high level of dexterity and continuous decision making. How does it do that? Before I do that, I'll just give you a minute of how does it really work.